Living it out. Good morning, welcome. This clock is a little bit fast and yet it is 7:30. So I will welcome us to our November Grand Rounds. Thank you for joining us today, both in person and on Zoom. Before I get to announcing Dr. Kenny Lamb's talk and introduction, our next Grand Rounds is November 20th. Dr. Mandy Peng and Michael Klein presenting on assisted living with highlights from Kavod. Next Journal Club is November or December? November, great. And I don't know if I have the accurate people here. So Jacob, who are the presenters?
Kate Runkle, to be determined.
Kate Runkle and to be determined. That sounds great. Following today's Grand Rounds, you will have an evaluation. Please do fill that out online or in person. Please submit questions to the chat. We are very excited that Dr. Lamb, one of our Geriatric Grand Rounds coordinators, is going to present today about functional decline and what we do about it. He's a geriatrician, health services researcher, and assistant professor here in the Division of Geriatrics and the Division of Hospital Medicine. His research program focuses on how to help older adults and their care partners navigate the complex web of long-term supports and services commonly relied upon as we age. He leverages a variety of research methods, including longitudinal analyses of secondary data and in-depth interviews with patients, care partners, and healthcare professionals. He is board certified in internal medicine and geriatric medicine in the US and previously in Canada. He has practiced in hospitals and post-acute skilled nursing facilities in both countries, helping patients recover, rehabilitate, and figure out if they can go home after a health crisis or if other services may be more appropriate given patient and family goals. For those of you who may follow Dr. Wen from the Washington Post, Kenny recently had a highlight of his recent publication in that newsletter, and we hope to be disseminating that out. But thank you so much for presenting. We're excited to hear your work.
All right. Thank you for that introduction, Hillary. And it's nice to have a home turf Grand Rounds. Hopefully I'm able to share a little bit about what I've been working on and draw some ties to the other Grand Rounds we've heard this year, as well as work that's happening in our division. The talk is titled Functional Decline and What We Do About It. And to start, I don't have any disclosures. And I'll state that the objectives of this talk is that by the end of it, my hope is that everybody here and listening online will be able to appreciate the central role that functional decline and its support plays in the clinical care of older persons. And also, we're going to get a little bit into the weeds. I'm just going to warn people in advance that I hope to describe some of the conceptual challenges that exist when you're trying to measure functional decline, and obviously a related concept of caregiver burden, how its impact on family members. And we'll conclude with a bit of clinical application where I try to put it all together and just say, I hope by the end of this, we're able to define as a group, who's the average person who moves into a nursing home or assisted living facility, recognizing that averages tend to have outliers as well, but at least we want to know what the average is. The start of this talk, I'll make a case, which should probably be Kool-Aid that most of the people in this room have probably already taken. But I'd like to at least outline why, in clear terms, should we study functional decline. The first reason why is that it is an emergency for older adults. If you look at survey data asking older adults why they go to an emergency room, 1 in 8 say it's because they can't care for themselves at home. It's not because of some specific medical reason. Anyone working in ED consults knows this very, very, very well. So it's supported by evidence. This is a photo. This is a family physician who worked in the University of Toronto and also was a photographer. And these were the pictures that he took of his patients when he was doing house calls. So just showing this picture of what is it like when people, as we get older. Functional decline develops under our watch. This is a famous image called The Hazards of Hospitalization, is issued in 1993. It's this idea that the hospitalization itself, not only do people come in when they're coming onto acute health crises that cause disability, hospitalization itself poses risks of becoming deconditioned and disabled. And so this is something that anyone who's been through residency, worked in a hospital knows and has seen, but maybe not been able to give a clear name to. And 1 out of 3 hospitalized older adults basically leave with a new disability, a new problem in an activity of daily living. This has major implications for patients. For hospitalized older adults, 1 in 10 will end up moving into a nursing home within 6 months. Nursing home is one of the most feared transitions of late life. And so it feels like a big deal for older adults. It matters to patients. It has major implications for caregivers. Because of functional decline, caregivers provide an estimated $600 billion of care every single year. That is unpaid, supporting older adults with functional decline. The estimates for the total amount of caregiving in the US, it's about like a little over $1 trillion. So they're providing the lion's share of care in dollar amounts. And I think it matters to us as healthcare providers because as clinicians, we actually authorize supports. This was something that I discovered as I moved to the US and tried to figure out how the system worked here. The disability structure in the US set out sort of in the 1950s was based off of this model that I've described at the top. That in order to have a disability, you could imagine to get the right to have, that parking permit that gets you that nice parking spot in the front, near the store, you need pathology. You need to illustrate how it causes impairments. You need to illustrate how that causes functional limitations. And only then do you actually have disability. Otherwise, it's just an advantage that shouldn't be afforded to everyone. So as clinicians, we play key roles in defining these pathologies and these impairments. And we also actually sign forms, as some in the room are very well aware of. We sign forms indicating what these are. And so it is our signature that is, and actually our clinical determination that defines these constructs in society. And also basically whether or not supports will be paid for or won't be paid for. Sorry, to link it to supports. And I would argue that we don't really have a lot of evidence to guide these authorizations. I mean, I've fought prior auths in post-acute SNF with insurers, and it's just like, what are we referencing to say, yeah, I actually think that keeping this person a little longer would improve their delirium and would make their transition home. It's not even actually about the transition home, but their delirium would improve more and faster if they stayed in a facility, in a supported environment, not sort of left to their own devices at home. But there's no evidence to make that argument. So you can't win against an insurer if they really say, well, prove that to me. It also comes at an unsustainable cost to society. This is a policy issue. It's become a hot topic. Back in 2020 in the VA, they were projecting that the costs of long-term supports and services would balloon. You can see the number just keeps growing through 2037 as you project out how many people will have functional decline and the expected costs of caring for it. And this is becoming a major issue in Colorado already as well. The governor just stated that Medicaid spending in Colorado is unsustainable and that it's mostly driven by long-term care costs for older Coloradans. That HCPF or HCPUF, these people make up 5% of Medicaid enrollees, but they account for half of all claims. So it's expensive. We need to figure out how we can do better or get more bang for our buck or something. If you want to break it all the way down to the patient and family experience of it, they want more guidance. These are results from interviews that I conducted with people who moved into assisted living facilities and nursing homes, both patients and caregivers. So assisted living residents say things like, I really wasn't sure what I needed. I was responsible. This is assisted living resident, so she's paying for her own care. She wants some advice as to how much she should pay out of her own pocket for this. And she says, I knew about retirement places and home caregivers are there, but do I need them full-time or for part-time? And what if you can't research? Or what if you're Alzheimer's or you're debilitated and you don't have friends? When I was sick, it was really hard to try and figure anything out, and it's very complicated. So people get very little guidance as to what they're supposed to do. And I also think as clinicians, it's very hard to know what is the right thing to do other than from our own personal experience. And you can imagine also from a child's perspective whose mom is asking, I want to go home with you. I want to go home with you. The son is asking, could she come home? This was a woman who had a high-level C-spine injury, a C3 injury, and was newly quadriplegic. And the son was still asking, could she come home? Could she live in my sister's house? Maybe. So what's the way out? These are 2 really popular books, I think, in our field that have made public attention. We've got Outlive by Peter Adia, who's not a geriatrician, but a surgical oncologist. And we have Elderhood by a geriatrician, Louise Aronson at UCSF. Outlive's strategy, and I think both are valid. Outlive's strategy is we should prevent this. And I think that that's valid. I think that that has merit. My only concern is that as a clinical geriatrician, while we wait for the image group to solve the problems of aging and prevent this from ever happening again, I think clinical geriatricians, we will be caring for patients over the next several decades where they will not be able to have the benefits of that research. And in Peter Attia's book, he draws this very compelling diagram saying, well, what we need to do in medicine is not extend people's lifespan, but increase their health span. We want people to live functionally intact for longer, and that is the goal of what we should be doing. I think core to both of these practices, whether you're sort of in the outlive camp or the elderhood camp, is that we need to define what in the world health span is. If we can't define that, how in the world do we know if we are doing a better job or not? The other thing that we need to recognize is that, yes, as clinical geriatricians, I think that even if we're caring for older adults where their health span has started to deteriorate and they're going down this curve, we need to know, are we pushing them back up the curve, or are they going farther down? And I think that this will be a problem that even if we achieve these goals, again, we will still be caring for these people just when they're 90 plus as opposed to when they're 80. So I think this is a durable problem that is in our field, and it is integral to geriatrics. The whole idea of functional measurement, it came out by a geriatrician, Sidney Katz. He worked in a long-term care facility, and these were people that were largely written off. And he said, I don't have a metric that I can use to figure out whether or not our rehab initiatives or our treatments are making people better or worse. And that's how he developed the ADLs. The main idea was, I need something that this is actually the thing that distinguishes people who are doing better or worse, and I need a sensitive measure to be able to detect these changes. And this is probably one of the biggest ideas that comes out of geriatrics. Since then, it's been used to track outcomes, prognosticate, triage resources, and also communicate about patients. Very pleased to see, internists now also say things like walks with a walker, or at least some broad sense, though not very precise. But at least it's making this is the way we've been slowly geriatricizing the medical system. Now, the thing is, measuring function is very difficult. And I hope by the end of this talk, I'll explain why I think we have so many problems with measurement in geriatrics, and why measurement, even though it's a bit of a wonky topic, is really, really important. I'll try to ground this in a more clinical or operations-based case. I'd worked on getting a level 2 geriatric ED accreditation back at UCSF for the San Francisco VA. And I would say the conversations that we had in broad brushstrokes were something along the lines of, we really want to know which of our older ED patients need more support. And so we're going to incorporate some measurement around ADLs. And then when you throw that in front of people, they're all like, do we really need to ask all of these questions? I'm seeing some nods from the audience, so at least I know that I've hit some nail on its head. And so we did this interesting study where we took a user-centered design approach to this. Rather than assuming, well, we could have told the clinicians, you got to ask the questions exactly this way. You got to ask all of these activities, every single activity, and you got to ask it specifically with these gradations. We said, why don't you tell us what in the world it is that you want to know? I'm going to assume that as a clinician, you've got some sense as to what it is that's important to you. And let me compare that to, again, our wonky theory stuff. So this is the classic diagram that you use in a user design study. You start with needs finding, where you do focused interviews to really clarify and pin down what is it that they're asking for. And then rather than asking people to elaborate on that, you just propose potential solutions, and you put it in front of them, and you ask them to critique it. So we started by doing interviews with several ED staff, and they said things like, well, the information about caregivers and services is terrible. Half of the issues that we have here are because they're brand new each time. We're like, what does he need? And then we'll wait, what does he even have? So there's this sense that people have supports, but we don't always know what they are. They're not up to date. And also, we don't have a good way of appraising what people need. So rather than asking people to clarify, well, explain to me what you need and sort of confront them that way, I said, okay, I'll take that back. Let me put together a couple of options of how you might want to display this data. And so the design product that we were thinking about was, you want to use this in clinical practice. If I gave you this data, tell me useful or not useful. And if not useful, why not? What are you feeling? What are you thinking? So we mocked up a couple of different ways that we could imagine we present information about services and caregivers. So here, for example, you might have an older person who gets Meals on Wheels and has an IHSS caregiver or an in-home support services caregiver paid for by Medicaid, and might have a daughter who helps out, and maybe you want some information about what they help with and how often they're there. Or maybe you want to look at the thing on the right, which is probably how a lot of functional assessments appear in charts, certainly in text-based CPRS charts, as happens in the VA. You just get a block of text and you're reading it. And so I'd ask them, what do you like about each? Which one's better? And then you get feedback. You put it in a focus group, you have people talk, you see if heads are nodding, whether or not people are in agreement. The ED doc said, well, it does need to be structured. We prefer the thing on the left a little bit more. Also, I think seeing the indication first would highlight the need, the functional deficiency. We want to know why the caregiver is there, not just that there are caregivers. And I also want a score that defines high or low functioning. And I thought, okay, not easy to answer. And the reason why, to show you, this is the Geriatric Resource Library from the OAIC. And these are the physical disability instruments that exist on it. I know it's very, very small text. In fact, I have this nice little animation to show there's actually a lot of instruments. And each instrument differs in terms of the activities that it has and how it's asked. And how do you choose? How do you choose which ones you want, which ones you don't want? How do you define what is high or low functioning? Which population is it tested in? This desire is very reasonable, but solving it is very thorny. This is peeking in on just one of those scales. This is the NHATS activities of daily living measurement. And I'm not going to go into the detail of it. The whole point of this is just that the process of asking questions according to the schema is quite complex. Briefly, if you just look across the top, they ask not just what people are doing, but how often it happens, whether or not they get assistance with it, whether or not they're dependent on other people, whether or not they have difficulty when they don't have assistance, and then also, did they feel like they needed more help? And so you have a lot of things that go into this. It's very, very nuanced, and turning it into a survey is not straightforward. So rather than say, well, you got to ask, like, let's just pick one out and you got to use it and just, we got to do something to satisfy this accreditation. We went back and I just put a lot of these activities in front of people. And I said, in or out? And so, you can see the ones that we crossed out. I asked like meal preparation. Should we measure that in the ED? Now, even for vulnerable older adults, food is a second tier issue. I know that might rub people a couple, but it's important to just recognize who are we talking to? What is it that they want? Because if they don't believe in it, they will not gather the data and it's all just a wash. Housekeeping, pass. Laundry, pass. Shopping, we see veterans who haven't eaten, but we don't even know what to do with that information. We're the emergency department. Finances for primary care. I did push back on that a little bit where I said, I think we need to work together on this, not just push it onto primary care. Transportation. This is where things get interesting. We would actually like a lot more detail on transportation. It comes up every day as a facilitator of disposition and post-ED follow-up. Medications, yes, but does the caregiver give meds or do wound care? That's what I care about. Transfers, helpful, as it includes toileting, bathing, getting out of bed altogether. And this is some of the reason why when you ask them questions about dressing, getting around inside, eating, they're like, I don't, if they can transfer, that gets me most of the way there. That's all I care about. Toileting, actually, we don't want to know about toileting so much as continence. Very controversial activity, appears in some scales and not in other scales, but clearly the ED wants to know about continence because it impacts the care in the ED. What this made me realize was that I think some of the theory around functional measurement hasn't really been well explained. And I think in our excitement to adopt functional measurement in a lot of our practices, we've overlooked some of the theoretical constructs that we need to inform these decisions. This is the WHO's International Classification of Functioning, Disability, and Health. It's probably it's trying to be the most widespread theory around functional measurement. And function kind of embodies the middle tier here. You have functions of body parts, then those let you do activities as a person, and that lets you participate in society. Health conditions can impact any of these and the ability to do any of these, but the other key component here at the bottom is the idea that your environment and what's around you, the supports, impacts your ability to do these things and how body functions lead to inabilities to participate. And also personal factors. So your own beliefs, your willingness to participate in rehab, your willingness, your beliefs that you could actually overcome this also play a role in this. And there's a subpart of this theory that talks about the difference between capacity and performance. Capacity is this idea, can this person do it in a standard environment? If I took this person and dropped them in a standard American toilet, whatever that happens to mean, caveats, lots of caveats to this, but if we were to drop them in that situation, would they be able to toilet themselves? Performance is the question, does it get done? And I think that this was the issue that's coming up. The ED was not interested, let me see, yeah, the ED was not interested in capacity, which is largely what these measures were previously designed to evaluate. That's why you want this scale, because you're trying to figure out where on this overall place they are. They're concerned with disposition. They're largely interested in performance. They want to know, will this get done? And actually not just performance right now, they want to know about performance and predicting performance once they go home. That is actually the concern. And that's the disconnect between these measures and why, when you try to apply these measures in this other environment, it's not actually suiting their needs. We came up with this final format. We actually sort of abandoned the whole sort of idea of function. This is what they wanted. And this is sort of in CPRS lingo. This is just to make it look like this might be what might get in a chart. If you happen to be in the ED, and they did endorse it, they said that this would probably be quite helpful. But largely the assessment of function, they said, I just want to know, sorry, it's small. It says, I just want to know, is the assistance inadequate? So again, they didn't want to think about how you would know whether or not performance was inadequate, or how you would predict whether or not performance would not happen. They just wanted someone else to tell them. So this was where it became very, very clear. They were interested in performance. They weren't actually that interested in functional measurement, but they were interested in at least knowing what services were there. So we called this the best possible caregiver history. I said it's kind of like a medication list, like you kind of at least need to know what the person is on in order to know also, is it appropriate? But they didn't want to think about appropriateness whatsoever. Pause for a moment, and we're going to switch gears to another project that I was working on with regards to functional measurement. And this is functional measurement in skilled nursing facilities. So there are really only a couple of places in the US where you can get broad data on people's function. One of them is the National Surveys of Health, which we'll look at a little bit later, amongst older adults. The other one is in post-acute care or skilled nursing facilities. Anyone who moves into a skilled nursing facility needs to have an MDS completed, or a minimum data set completed. That includes a section known as Section G, which is functional status. And what only some people know is that in 2023, Section G was retired and it was replaced with Section GG, very closely named, functional abilities and goals. And things look kind of similar. Yeah. And the issue is that Section G there's a paper where they took Section G and they turned it into a scale and they validated it. It's one of the more cited papers in the journals of gerontology. It's been cited over 1,000 times. And a lot of research has basically relied on this scale to talk about who is in a nursing. And you can imagine now, because of this Congress mandate, they changed the measures. You can't create this measure anymore. So as of 2023, we don't actually know how to compare how people's function is being measured now to how people's function used to be measured. It turns out that you can't just add things up. This was something that I learned as I worked with Roe Gutman and Vince Moore's team. And I'll try to illustrate this. Let's see if I can break this down in simple terms. Imagine I created a test, and these are the math questions on this test. And you can look at them. Like, clearly question 6 is considerably harder than questions 1 to 5. Imagine you have person A who scores 4 out of 6, person B who scores 5 out of 6, and person C who scores 6 out of 6. And the ones, they definitely get number 6 wrong. I would ask you the question, is the functional ability or the mathematical ability between person A and person B the same as the difference between person B and person C? You'd probably say no. Person C probably knows something about math in order to answer that question. That means that they're actually their skill is far higher than the other 2 individuals. The same thing happens with activities. Anyone practicing clinically knows that these activities are not all equal. If you can roll left and right or move around in bed largely, that includes sort of sitting to lying, lying to sitting. That is vastly different from being able to climb a flight of stairs. And yet we don't really think about this, or this isn't really operationalized in any of our measurement. It was in the previous scale. This is we'll talk about this in just a moment. So this was operationalized in the previous scale. I'm sorry that it's small, but it's because I'm making room to show you how section GG is very different from section G. The old MDS scale relied on these 7 measures: dressing, personal hygiene, locomotion on the unit, toilet use, transfer, bed mobility, eating. This figure on the right is the result of something known as item response theory. It's what they use in SAT scores to also rank people. And each dot represents, the x-axis represents someone's ability, and each dot represents whether or not a question probes that level of ability. So you can see here that dressing, so on the right-hand side, so you can see here that dressing is the hardest ADL to complete because it's farthest to the right. And the reason why there are multiple points for each activity is that questions about dressing don't just ask, can you dress or can you not dress? They ask, do you need a ton of assistance to dress? Do you need a moderate amount of assistance to dress? Do you need a minimal amount of assistance to dress? Or are you completely independent? That's what each of those dots represents. Does that sort of make sense? So you can scan across and you can imagine as you have higher and higher levels of ability, you basically, if you cross one of these thresholds, it means that you'll answer the next level of that question. This is a graded response model of item response theory. The main takeaway point is that you have these 7 tasks. You can order them in terms of difficulty, though that's a little bit nuanced because of the gradations that you have within each activity. And then in the new MDS scale, they added all of these activities. And the question then is like, how do you translate these two? And this diagram helps you show some of the problems when you try to do this, because what you clearly see is that the eating question and how its wording changed means that it detects people at far lower levels of ability that the new measures actually don't interrogate at all. There's no question in the new set of activities that gets at the high level of impairment of people who are totally dependent in eating from the old scale. So you don't have that anymore. The other thing that's very, very clear, or if I can point your attention to, is that in the new scale, several of these measures, like what used to be bed mobility, became these 3 measures: lying to sitting, sit to lying, roll left and right. And you can see a lot of these threshold points, they line up exactly on top of one another. And what that means is that as you cross these thresholds, if you added all of these up, you'd get 3 points because you would go from being like mild assist to independent in lying to sitting, sit to lying, and roll left to right all at the same time as you're recovering. And so you can imagine this creates all sorts of problems when you're trying to do science on this, because if you are doing an intervention, like a +3 at one range of the scale is not +3 at another range of the scale. Does this matter? Yes. So this is actually results from a study of 2 national surveys of aging. And here, these are questions that both of these surveys, I'll just focus on 2 of these surveys, NHATS and HRS, the Health and Retirement Study, because I know them quite well. But difficulty in dressing is ostensibly measured in both. But because of the differences in how these questions are worded, the estimate of the prevalence of people who have difficulty with dressing is almost 2-fold in NHATS compared to HRS. And also same for difficulty in eating. So you can see, it's like 18%. If you ask like how many people have difficulty with dressing, in NHATS, they would say 18%, and HRS, they would say about 10%, which is to me pretty concerning, given that the sampling frame for both of these surveys, this is supposed to represent older adults in the US. You're supposed to be able to rely on either of these to estimate functional impairments in the US. So we have some problems. It's also the basis for multi-million-dollar trials. I present this because Capable is probably one of the leading trials that has tried to improve ADL performance in older adults. And the effect sizes in that study are quite small. And so you can imagine it's sensitive to how you do these measurements. The other thing is that XPRIZE, I think, offered over $100 million to try and improve health span. And then they discovered they don't know how to measure health span. So they offered $10,000 of the $100 million to get people to answer how do you answer what is normal health span and what are normal declines. So I just need to bring up, like, this is a subtle point in geriatrics that I really wish as a field we owned. And the reason why I think about that is that, if you were to talk to a nephrologist and you were to say, oh, his creatinine went up like 1 point, or 2 points, or 10 points. Everybody knows that creatinine doesn't work. It's not really a clear measure of function. It's a proxy for it. But the thing we're trying to measure there's nuance to that. And I feel like as a field, as geriatricians, we should really know this, that we should claim this as our expertise, because this is what we spend our time working on, thinking about, and seeing and asking about day in, day out. All right. Now, I mentioned earlier, most care for functional decline is provided by unpaid caregivers. How do you measure the impact of that care on the caregiver? That's caregiver burden. Similar problems exist in this field too. I learned this because I was studying Reddit. It's an online forum. People can post pseudo-anonymously. They can, make up whatever name they want and write what they want. I do take my work a little bit outside of my work hours. I lurk on caregiver support Reddits just to find out what it's like for caregivers and to hear what their complaints are. This was one that I saw. A son was complaining that a social worker did minimal work to find a safe post-rehab place. Left a message. The social workers reported him to Adult Protective Services. He's very mad. He believes he's in trouble. This is a shout out to you, Elizabeth Blumen, because I just thought this is a form of caregiver burden. But is this measured by any of our burden measures? It's clearly annoying enough that he swears, right? There's an expletive in the comment. What is it? What is caregiver burden? This was first coined in 1980 by Zaret. And the idea here was, well, we have nursing homes, but not everybody moves into a nursing home. Families care for some people at home as well. And we need to enumerate the costs that they take on in terms of the tolls it takes on their health, psychological well-being, finances, social life, and relationships, in order to basically have a fair system in allocating nursing homes. Because otherwise, people just we're not recognizing all of this other stuff that happens, and otherwise we can't figure out how to allocate who gets a nursing home or who doesn't, since it comes out of public dollars. These are four of the most sort of salient questions out of the Zaret, and you can see that it's reflected in the way they ask questions, right? Do you feel like you don't have enough time for yourself? Are you stressed? Are you strained? Is that affecting the relationship? And maybe do you not know what to do about your relative? So what did we do? I said, well, there's a lot of interesting stuff in Reddit, but we should probably read a little bit more systematically. So we scraped it. We pulled about, we looked at 5 subreddits. We pulled 500 threads from each. And then we created a code book. We coded it. We analyzed it. Here are the results. It really came down to sort of these 5 themes. I'll highlight also, we were looking for posts where people described their difficulty. And probably the posts that were the hardest to categorize were the ones where people asked for help around a specific thing. Like, social worker told me something about Medicare or Medicaid and I should enroll early. What do I do? The thing was that I couldn't really say that that was a difficulty, because they're not saying it's hard per se. They're just saying, I don't know this. So that's just one caveat. So we didn't include those, but we include anytime someone made a complaint. And I think that this is just very telling, or this is much richer, I think, data-wise than a burden measure illustrates or communicates. We honed in really on 5 themes. Personal sacrifice is this idea that, yes, caregiving costs. And I think that's not intrinsically a bad thing, but people did talk about how they lost things. And I think that this is probably closest in line with the Zaret theory of what caregiver burden is. The other thing that's closely in line with caregiver burden, according to Zaret, and the measurement of it, is resentment. Right? I feel only a little love for my grandmother now because of how badly she's treated me. It's like transformed this relationship, and now the thing that's hard is the resentment itself. That I used to love this person and now I don't, and that is hard. That's a hard feeling to deal with. The domains that aren't measured very well in the Zaret, though, are burnout, family relationships, and long-term care. And here, burnout, it sounds similar to personal sacrifice, but I think here we were honing in on something more specific. Burnout is this idea that it feels futile. This idea that, it feels like I'm living in hell. And the hardest part for me is that I can't change anything. This idea that, I can't figure out if my care is worthwhile because it feels like nothing makes a difference. Family relationships, it wasn't specifically the dissolution of relationships, but it was actually how family members could make the caregiving itself more stressful. I think a lot of people can relate to this, that it's the feeling that you're doing it, but nobody else is, and that it's unfair. And again, the Zaret measure doesn't really ask or probe about that. And lastly, the other element that's not measured well by Zarit is the way that the system is also very difficult to navigate and frustrating. And that's where we ultimately classified or thought about that APS comment, that it's just, there's a lot of confusion. For what it's worth, we left that as a minor theme because the caregiver support Reddit, these Reddits the members did respond many times to say, no, APS is actually a resource and not punitive. So I can tell you, at least in online forums, the caregivers are giving reasonably good advice around that topic to one another. What this led to was me trying to think through, if we were to reframe or rename or maybe clarify this caregiver burden model, how would we think about it? And the way that I think about it is, I think people take on sacrifices and they ask themselves, is this a benefit to the person that I'm caring for? And this is idea, this is an older idea, but it's an idea of caregiving appraisal. Is caregiving worthwhile? And I actually think that it manifests differently based on what people believe is ultimately responsible or only responsible. If you're the only person who's responsible, you get burned out. If you think that the care recipient should be doing more, you start to resent the care recipient, or if you think they should be doing something different. If you believe that your family members, other people should be sharing the burden with you, then you get more conflict with family and you get more conflict with long-term care. And all of this is important because one of the big problems with caregiver burden measurement is they started to analyze this across, races and cultures, and some people aren't willing to endorse things like resentment or that it is a sacrifice whatsoever. And I wonder, maybe they would be willing to say, though, I feel like what I'm doing isn't helping at all. And if you ask the questions a different way, again, how you measure things, it's very important because it leads to issues of fairness. It leads to issues of knowing what it is that we're talking about. The other thing that matters is that theory informs care models. We have the care ecosystem, which was largely a positive intervention focused on navigation. But in 2025, we had 2 negative trials, pragmatic randomized controlled trials, DCARE and INPEACE. And you can imagine if the focus is on navigation, but your outcome measurement is this Zarit that focuses on resentment and personal sacrifice and the costs, it doesn't really help with these issues of family conflict or burnout or long-term care frustration. It probably helps with long-term care frustrations, but that's not the outcome that you're really measuring. And so I just wonder whether or not, again, some of our weaker theory and our desire to sort of respond to something quickly has gotten in the way of us thinking very, very clearly about what is it that we are trying to intervene on, what are we measuring as a result, and what's the outcome of interest. Last, to get a little bit out of the weeds, more into sort of stuff that's palatable to a regular audience, I just wanted to define a milestone in functional decline. So, we've got this nice picture here, and I just wanted to say, okay, health span, really complicated, lots of pieces to it. How do I just define a clear line in the sand? Almost like, like a creatinine, at which point you would think about dialysis. And, the moment that happens in geriatrics is really long-term care entry. It's important. Most of us, as I've mentioned, will develop severe disability in our lifetime for around 5 years. A third of us, based on prior projections, will end up moving to a nursing home or assisted living facility. There's 1 million AL beds. There's 1.3 million NH beds. And what influences the transitions into these facilities? The things we just talked about: age, cognitive functional impairment, caregiver burden. To hear it from the residents themselves, these are the interviews that I did with the residents, which is what we analyzed. It's very clear that it's acute crises. Something catalyzes the move into these facilities. It's not as common that people move over a gradual period of time. I got a terrific infection in my right hip, a lot of falls, right? I was robbed twice. I fell down 9 flights of stairs. I pierced my lung, broke a rib, pierced my lung. I needed to be on oxygen. I didn't know how I'd do that at home. I was called a liability where I was living, and then I took a fall. And could you imagine the horror when you suddenly can't get up? And all of this feels very unexpected to people, right? It's changed my whole life. It's insane. I never had a problem, falling. This is just a total departure from their prior self-conceptualization. And this happened whether they moved into a nursing home or an assisted living facility. And quite nicely, you see this reflected in the quantitative data as well. What you see, I'll highlight just the bottom 2. The reason why I included a little bit about being, called a liability, why would I want to keep living in a place that thought that I was a hindrance, is that there's really 2 kinds of entryway. One I call is the acute phenomenon, and the other is the acute on chronic phenomenon. That some people, there's like harbingers. You can see that things are not working, and then you still need the catalyst to then prompt them to move into a facility. But it's kind of like dialysis. Long-term care, though, you can see this in the quantitative data, aware of all these nuances in measurement. We then looked at the National Health and Aging Trend Study, which you saw sort of how they measured function just a little bit earlier there. They do annual interviews of Medicare beneficiaries, and they ask, where do you live? How's your function doing? And, this is the figure where I show, well, yes, it is an acute on chronic phenomenon. You see that people are trying to make it home with escalating levels of severe disability or likelihood of severe disability. And then at time zero, that's the moment they move into the facility. There is a jump in the prevalence of severe disability because a lot of people are having events happen to them that render them disabled. And you see this happening in nursing homes, which is not surprising, but interestingly, you see this pattern also in assisted living facility, though to a lesser extent. We just talked, though, about how function is a scale, and this is not a scale. You'll notice that I define severe disability here. This was a deliberate choice. It was because this picture is very hard to interpret. What this is now the median functional outcome score. So now you're thinking across the population, you have the scale of how well people work. How is that rising? And so this supports the idea that they are in fact becoming more disabled slowly, right? Because this is now the continuous scale, not a do you have severe disability? Yes, no. And you can see here, the really interesting thing is that the trajectories of people who go into a nursing home and assisted living, the median level of ability is actually quite similar. And then this illustrates that the catalyst, the degree of new impairment is much higher for the people who move into a nursing home as opposed to an assisted living facility, even though the picture or the figure of the lines look kind of similar. But we didn't end up publishing this as the main graph because the same problem that I've been highlighting earlier, this functional scale is just so hard to interpret. Like, what does it mean that someone has a functional outcome score of 16? Like, I couldn't communicate that or put that into words in a way that was evocative, and that's why we did it. But you can see why this is an important analysis as well, because it tells you something about the level of ability of people before they go into a nursing home versus the people who before they go into an assisted living facility. It's quite similar. They're on the same overall trajectories. We also mentioned that function is not just body functions or activities, the ability to do certain tasks, but also participation. This is what motivated this paper that asked also, well, what happens to participation? And in fact, this theory informs the interpretation of these results. Similar data set, now looking just at the people who go into nursing homes and assisted living facilities, and looking at these questions, yes, no questions, asking, do you visit with others? In the last month, have you visited with others? Have you gone out for enjoyment? Have you attended religious services, participated in clubs, or volunteered? And you can see on the left-hand side, socialization, these more spontaneous actions, they are going down. And there's that, again, stepwise decline in going out for enjoyment once people move in. But on the right, community participation, your ability to participate in the community you happen to be in, it jumps up when you move in. And so people tend to attend more religious services and participate more in clubs. And I wanted to study this just because I think we have a lot of stereotypes and beliefs about what happens, but this is probably the first national data to say what does happen. And we interpreted this as saying, I didn't want to talk too much about going out for enjoyment because, as you saw earlier, if you are newly disabled, you are less likely to go out for enjoyment no matter what. I don't know how much of that drop is due to that disability versus the move into the facility. On the other hand, for community participation, if you are newly disabled, I'm pretty sure your community participation, all else equal, is not going up. So the fact that it's going up lets us conclude that it is likely the move or the change in the environment that is doing that. There are obviously open questions as to whether or not this activity is meaningful. Is it all just bingo? Is it actually religious services that people find a lot of meaning in? I don't know. I wanted to answer that. We actually spent some time trying to figure out if other questions could get us to that. There weren't questions that would be valid to analyze. The other thing was, I wanted to study caregiver burden. We're waiting for those questions longitudinally to come out. That should appear in NSOC, which now samples annually as of 2021. I'm just waiting for the data to accrue. But in lieu of that, we ended up just looking at caregiving hours. And here you can see, this is why I state this picture. On average, before people move into nursing homes and assisted living facilities, as everybody knows here who's practiced clinically, people are trying pretty hard at home. How does this all, fit into sort of clinical practice? I think when we talk or think about a continuum of care, we've long known that as people develop worsening levels of impairment, that's the x-axis or rows along that first row along the top as you go right, they can go to higher and higher levels of care, either at home or in facilities or using blended models. And I just wanted to put, again, a flag in the sand to say, Well, if you're asking when do people, what is severe ADL impairment? When do people usually go into a nursing home? Here's the data support. It's when you have 3 or more ADLs impaired, defined specifically as a lot of difficulty in these activities or assistance. And then if you want a sort of midpoint for assisted living, it's 1 ADL impaired. And then while we wait for the caregiver burden stuff to come out, if you want to know what are the people doing before they move in, it's about 18 hours of care a week on average before they move into AL, 27 hours of care a week before they move into a nursing home. So we are finding people in the middle of a journey. This is a trajectory. People don't just die when they move into a nursing home, right? It is an ongoing part of their lives. Next steps, where do I go with this? I'm working on the draft of a perspective paper to help people think about how do you choose functional measures for clinical operations and research, trying to synthesize a lot of the work and research that's been done on functional measurement itself. I showed you this picture, this like totally messy scale, all the problems with it. Another project is to validate a new scale, and this would enable outcomes-based research in skilled nursing facilities. It's a great place to study function as an outcome, so we need to have a scale that can do that. And then last, I think here I highlighted earlier that left side thing, that functional outcome scale, like how do you interpret it? I think that's kind of where I'm thinking about things in terms of decision aids or communication strategies. How do you develop ways to convey those changes in function? We do all this measurement, we abstract all of this out. How do we return that to families and patients? Because they're ultimately the ones who are making these long-term care decisions. I don't know. We're thinking about like videos or like what could be done maybe, because otherwise, why do we just collect all this data and we hoover it up and feed it to the AI machine and it doesn't go back to help anybody? And so again, I would overall categorize my work by saying, yes, we've all had personal experiences, with our loved ones where, we don't know what to do. And I think a big challenge that's very core to geriatric is how do we turn that into data? Because the point there is how do we learn from one another's experiences rather than letting it all sort of like just become a terrible experience we went through. And that to me is how we will learn how to do better. So hopefully I satisfied the objectives. You can appreciate the central role of function and decline and support, describe conceptual challenges in measuring it, and then define the average person who moves into a nursing home or assisted living facility in the US. I'd like to acknowledge all the people who have helped support me. A call out to the colleagues, Josh and Tyson and Elizabeth, who I pepper with like seemingly random questions, but it helps me stay grounded that like what I'm doing is in fact related to clinical medicine, despite me going off the deep end and some of the wonkiness. And then obviously all the people who have taught me how to do all of these methods, and obviously the patients and families where this all stems from. Questions and answers.
Fabulous talk and open to questions.
Fantastic presentation, Kenny. My question is about the median graph that you showed.
Yeah,
Can you pop that up for a second?
I'll pop it up, the big one.
So I noticed there at about 12 months prior to entry, the nursing home and the AL, the trajectory changes.
Yeah.
What is happening? There's a slow increase until that point, but at 12 months, it's steep. So
Sure.
what's happening at that 12 months out? Can we use that as a predictive measure in any way?
We can talk about it. I mean, that's partly a result of the modeling, though we did check that. So we ran several methods. We used linear splines with different knots. We used cubic splines to smooth that over. We also compared it to the raw data just to make sure that these medians do overlie the median value in the raw data in itself. And I would say that there's another analysis that I've been working on, which we pitched in recently, but it's trying to think through a little bit more. If we were to decompose this median into its variability, how would we decompose it and think about that in a bit more of a nuanced fashion? If I were to just talk about it in clinical terms, like these are people with dementia that are suffering these long declines, and there's like a long tail or a long lead up period before they move in. And also people moving into nursing homes are people who have had like spinal cord fractures, who are like walking their dog, and then all of a sudden they can't move. And so that is, I think the question, maybe I would respond by saying, yes, there are questions about prediction. I think some things can be predicted and some things cannot. And that requires understanding the heterogeneity there, which requires totally different methods. More to come.
Thanks, Kenneth. Great talk. I'm gonna, I guess, just for a cognitive exercise, push back a little bit on the stance on health span. Such that you identified it as, rather than coming to the nursing facility at 80, you're coming in at 90, when the central dogma colloquially presented is it's about the life in my years, not the years in my life. So to pinpoint health span to one specific metric doesn't seem aligned with that central theme. But because then, so just to plant that seed, not to go back to what you're saying here, it seems like the functional outcomes or just overall function is what are you suggesting that that should be the one particular variable that that geriatricians focus on as their markers of health span to draw a corollary to EGFR the way nephrologists would?
Yeah, I think this is why I wanted to refer to the WHO's ICF, right? That it is this middle line that probably defines health span most. And I think that's even how it's colloquially referred to, right? Even in Peter Attia's work, right? Like we want to be able to move. There is some talk I know in his work around loneliness and again, participation. And again, that's why I wanted to include both of these studies to ask, well, yeah, they don't fully line up. And I didn't want to omit the considerations of participation as people move into nursing homes. So yes, it is, but I think the main point is just that health span, when you really get into the weeds of it, is a very squirrely thing to measure. The X Prize actually didn't include anything around participation whatsoever. They included mostly biological markers, right, like of aging, and a little bit more on the left-hand side of this figure, body functions and structures. And again, I'm challenging these ideas that that's not the whole thing. And if that is the whole, like if that's the only thing that you're working on improving, you'll miss all of the ways that investing in environments, investing in personal factors, the psychology of aging, changing the way we think about ageism, aging itself could potentially lead to increased health span if you took a broader view of it. So
as a quick follow, it's hard for any one particular investigator to focus on such a plethora of topics. Do you think that the field is moving to a direction where we can use artificial intelligence or machine learning to combine all these factors, right? It could be the circulating biomarkers that X Prize seem to focus on, biomarkers aging, combined with everything you're discussing. Are we moving toward a better quantification of health span by utilizing artificial intelligence or machine learning?
I don't think so. I think if anything, actually, the work that I'm doing qualitatively is illustrating this, right? Our words are mush when it comes to us describing these concepts. If AI is trained on those words, how will AI know the difference between these? So that's why I've run some of this stuff through ChatGPT. It doesn't do as good a job. It helps me with syntax, but concepts it doesn't. It can't.
We love this discussion. I'll also agree that like if functional status is the be all end all, it's an ableist perspective on the world. Even participation is an ableist perspective. So, Katie, such thought-provoking work. Thank you so much for presenting this. Back to your read about the entry. Yeah, but
Oh, sorry, this one.
yeah. So one thing that strikes me is how much higher your median is after long-term, like immediately after long-term care entry. So what's your thought there?
And I think that this is where the qualitative data explains it, right? Like this is someone who was struggling. I think one of the women, the woman who pierced her lung, if I remember her story correctly, she was talking about how she lived in this house and she had a garage door that was just getting heavier and heavier for her. She couldn't lift it up. And she was wondering whether or not she's like, when I turned 80, I just knew that I couldn't do this anymore. And what she described it as, I asked like, what happened? And it was this garage door that she was like, I can't lift this as much as before. So, and then with that, that's that rise beforehand. And then she falls and then she pierces her lung. And now she has oxygen that she has to put on a walker. She doesn't know who pays for it. The assisted living says like it's $3,000 a month sorry, the oxygen, the assisted living is $3,000 a month, but it doesn't cover someone to help her like put the oxygen in the walker and get her to the meal. So like that is that jump because she fell, she now has perforated lung, she's recovering from that. That's the jump.
Given that woman went through pressure.
Yeah, well, that's what's interesting because the capable study post-hospitalization was negative. And this is why I wonder, this is what I mean that like when we're thinking about these interventions, are we really understanding the trajectories that people go along? And are we targeting them the right way? So the capable post-hospitalization wasn't effective at improving ADLs. That's might have been before. That's right.
On your Reddit analysis, you talked about the fees, but there wasn't a finance lead in there. And I was just curious kind of where that emerged.
Oh, in terms of the costs, we put that in under personal sacrifice, and obviously this is a constant comparative analysis. So we're making some decisions as to what we chunk together. And then we're deciding, if you look at like the overall map of everything that's there, that's why these 5 did emerge. But you see, at least in this quote, we did mention and we elaborated on it within the sub themes, right? It's cost me significantly, both financially and mentally, so. Yeah.
I might have mentioned
Yeah,
last month where this woman was being paid
Yeah.
to care for her husband. Did I told you about this? And it was $5,000 his pension a month, and she was receiving $2,000 to do home caregiver
Yeah.
work. And he was on home dialysis. He was on chronic TBN at home. She was doing really high level care at home. And he was hospitalized 15 times this year.
Mhm.
And every time he would come in, they would say, why is he here? Why aren't you letting this poor man just, have his final moments and keep him comfortable? And the reason she was very authentic about it, said, I have nothing to live on. If he dies, I have no pension and I have no caregiving dollars. And so I wondered if so yes, it's a sacrifice, but it's also a benefit in some cases, right?
Yeah.
To be a caregiver and the alternative is to not have any income.
Yeah, I'm thinking through if we would have seen that. We might have seen that in Reddit. We actually have another paper around the positive aspects of caregiving, though the financial benefits didn't appear in there. Obviously, I think something like that wouldn't appear as a caregiver burden because they wouldn't describe that as a burden whatsoever. But there's nothing positive. Yeah, this is no. We did mention there are also positive aspects. We don't need to paint it in one broad brushstroke, but like I can only fit so much in one paper.
The sharp change with the nursing home admission, the graph underneath keeps talking about.
Yeah.
It makes me think that people have limited insight into their progression. And of course, there's a few things that happen that we can't predict. But it does make me wonder, like, are there other corollary studies, not just with aging and like long-term care placement, but like, are humans just bad at realizing how ill we are? And is that just the human condition somewhat?
Yeah, I think that's why what I had mentioned about the left-hand side of the graph, and I think that's what we would be able to discover or conclusively define. If we're able to communicate back to people, like, this is where you're at, and they're just like, I don't see it. You can imagine, but that's very important because if health systems are on the hook for that, it's like, this as a clinician, you sit there and this comes out when I do focus groups with post-acute skilled nursing facilities, asking them what they think about discharge. And they're like, I can't break this. But to me, you need some method to prove that that's the case. Because if you can't prove it, it's going to keep happening. My take is, yeah, it's going to keep happening. I'm trying to push the dial on like, how do we pin this down?
2 comments on Zoom, so maybe Connie, if you want to unmute and then all.
Yeah, and I think Kenny just really answered a lot of the question that so I was thinking about the slide that you just had up, Kenny, that had the trajectories of their ADLs before they were admitted either to a long-term care facility or an assisted living facility. And I wondered if we were able to collect that data before that 0, standardize it, make it high quality, could that be used then, and how could that be used to inform the discharge planning, both in the hospital and in the SNF? And I think you just kind of alluded to that just a little bit.
There is another project, and this is the work done by my colleague at UCSF around predicting nursing home entry. We're very cautious about that because it assumes that people who went to nursing homes should continue to go to nursing homes. So then another analysis was nursing home level of care and predicting when people hit that. I have some issues with prediction overall because I think that there are issues with fairness. There are issues with whether or not that's even what people want to hear. Like, Do you want to be told you have a 70% risk of going in there? That is a line of research as well. We could talk more about that if you're interested.
Thanks.
Did you want to make a comment? Well, thank you so much for.
There's a couple of us online who have some questions.
Fabulous, go ahead.
I'm sorry, it was difficult to hear you. There's two of us here online who have some questions.
Yes, go ahead, Nicole.
Okay, awesome. Hey, I'm Nikki Garrett. I'm a social worker in geriatrics at the VA. I really appreciated the information that you shared related to the incongruency between ADL assessments that exist. And in particular, my question is, wondering if you've taken a look at the Minnesota case mix tool in conjunction with the others that you reviewed. That is predominantly the tool that we utilize within the VA system of care. It weights heavily for individuals who need hands-on assistance for activities of daily living, but very minimally weights for those that need instrumental activities of daily living support. So someone who can physically feed themselves, put spoon to mouth, but wouldn't otherwise eat unless meals were prepared and put in front of them. This particular tool is utilized in a variety of ways, but sometimes is having a direct correlation to supports that are offered for that individual, including both home health, stipends that are available for caregivers and things of that nature. And so just wondering if you've taken a look at that one.
No, I can comment. I think what you're referring to is the resource utilization grouping, the case mix used for a lot of SNFs, or at least some variant of it. It is a slightly different method. It uses a classification tree in order to categorize people. And what it optimizes for is based on old data, looking at how many hours of care someone needs within a nursing home. Different countries, different provinces, places use different algorithms for it. My concern around the whole thing is that none of it is clinically based. It's largely given around, it largely says, well, these people cost us a lot of money and took a lot of care based on how people stepped up to care for them. And we should just keep paying sort of based on those cut points. And nowhere in there is a question, what difference does this make in terms of does this lead to better results? Does this lead to worse results? And I think that's the point that I'm getting at, that it's just saying the past is how things should go in the future.
So great.
Thank you.
Thought-provoking talk. Thank you, Kenny. Thanks all for participating today.